Welcome back to the Ninja Nerd Podcast. Today we're talking about chronic leukemias. We just finished last week with our podcast episode on acute leukemias. It was fantastic. We had a lot of fun.
Yeah.
If you haven't already, please check that episode out before watching this one.
Yeah, you got to do it. You better do it. I told you to do it. All right, just do it.
Now, for chronic leukemia, Zach, what would that one encompass?
It's chronic myeloid leukemia, CML, and then chronic lymphocytic leukemia, CLL.
All right. So we have two cases again, just like we did with acute leukemias.
Yeah, so you got a 50-50 chance that you're going to get it right based upon the case.
Based upon this first one. Let's see if you guys can get it, okay?
All right.
Here we go, case one. We have a 48-year-old male presenting with persistent fatigue, early satiety, and unexplained weight loss. The patient has experienced progressive fatigue over the last 4 months. He also reports early satiety, mild abdominal discomfort, and unintended weight loss of 10 pounds over this period. He denies fever, night sweats, or frequent infections. There is no significant history of easy bruising or excessive bleeding. For his past medical history, he has none. He has no significant history, no history of autoimmune disorders. He's currently taking no medications, that's 48 years old and you're not on any medications.
One can hope.
Man, that's impressive.
I'll be on like 72 of them.
Seriously, that's like, wow. For his exam vitals, BP is 125/80, heart rate is 85, temp 37 Celsius, and O2 sat is 98% on room air. His abdomen, he has a palpable spleen extending below the left costal margin. Skin, there is no petechiae or ecchymosis present. And for his lymph nodes, we assessed them, and there is no significant lymphadenopathy. All right, off to a good start.
Yeah.
We get some lab work back. We get the following. Hemoglobin 11.2, platelets 450,000, white blood cell count 120,000.
Oh my gosh.
We do a peripheral blood smear. We have increased granulocytes, basophilia, and a myelocyte bulge.
Yeah. Good old bulging.
Yeah, I was gonna say a bulge, huh?
It's definitely a term. I promise it is a real term.
Yeah, my mind went exactly where your mind went.
Cool. So true though. Yep.
Continuing off of that, we have a LAP score. The value is low. Bone marrow biopsy. We have hypercellular marrow with less than 10% myeloblasts. And for our cytogenetic study, we have a 922 translocation, or a BCR-ABL1 fusion gene. So we got a whole crap ton of stuff going on. We got a lot of testing right away.
Yeah, I know.
And we got a lot of information to go off of. So we have a lot of findings. What do they suggest?
All right, so if we kind of dig into this, the patient comes in with persistent fatigue and satiety and weight loss. So the fatigue, sometimes that's always a kind of maybe a ominous sign of anemia. That could be one thing. And then the hemoglobin, look, it tells us this is a male. Less than 13 is defined as an anemia for the hemoglobin. It's 11.2, so there's some anemia. Don't really know the exact reason why, but we talking about leukemias here, so it's probably infiltrating the bone marrow. That's probably the reason why, crowding out that space. There's no signs of any bleeding, so that's good. There's not enough of the actual leukemic cells there to kind of crowd it out enough to cause the platelets to drop. And the platelets are actually normal, so there's no petechiae, ecchymosis, and the platelets are within normal range. So that's good. White blood cell count is out of this world.
Yeah. So
it's definitely a significant leukocytosis. So funny enough, CML and CLL are classified. So you remember I told you like AML, ALL, it's like variable, could be really, really high, could be like, normal, could be mildly high. Usually in the chronic ones, they're always like through the roof.
Okay.
So they're always pretty high. So that's one definitely the thing to be considering is usually you'll see white cell counts that are near 100,000 or above 100,000. So that's definitely concerning. It doesn't really specify which one until I get to the peripheral blood smear. So once I get to that peripheral blood smear and it shows me that I have granulocytes, that tells me it's not the lymphocyte lineage. It tells me it's the myeloid lineage. So right away I'm thinking it's CML as compared to CLL.
Okay.
Because if I saw that they were saying increased like mature appearing lymphocytes or smudge cells, that's the term, you think about CLL. In this case, it was increased granulocytes, basophilia. That tells me, oh boy, this is definitely the myeloid range. That's definitely the CML.
And of course, that myelocyte bulge.
Yeah, so let me specify what this means. Okay, so there's lots of granulocytes. That means there's lots of neutrophils, basophils, and eosinophils. You don't see basophilia that often. It's a pretty rare finding. There's kind of one kind of scenario where you can consider it, and this is one, is CML. So if you have a patient with a super high white cell count and they also have an associated basophilia, you almost always think CML. Now, when you look at the peripheral smear and it shows a myelocyte bulge, you have to go back to your basic kind of like hematopoiesis, where you go blast, then you go to a promyelocyte, then you go to a myelocyte, then you go to what's called a metamyelocyte, and then from there you go to a band cell, and you'll finish off with your normal neutrophil or your granulocyte. We'll just say the neutrophil, eosinophil, basophil. So what happens is there's two different diseases, and you actually have to remember this, okay? It's called a leukemoid reaction. So if I have a patient comes in, white cell count's really high, less than 50,000 though. You don't see leukemoid reactions bumping up above 50,000. But let's say that this patient had a white cell count, and it could happen. Let's say their white cell count was 48,000. All right. I don't know if it's a leukemoid reaction. I don't know if it's CML. All right. How do I tell the difference? Well, first, CML is a neoplasm. Leukemoid reactions are basically leukocytosis in response to infections or stress or some type of inflammation of the body. So that would be something in the history. But the next thing is you have to look at the peripheral blood smear. If I look at the peripheral blood smear and it shows that I have basophilia, that suggests more likely for it to be CML, because you don't see that. You see neutrophilia as the predominant one of leukemoid reactions. Second thing is the myelocyte bulge. It's just so funny every time you say it.
Yeah.
So when you think about leukemoid reactions, it's a natural response to an infection or inflammation. So go back to the stages. Promyelocyte, then you're going to go, or blast, promyelocyte, myelocyte, metamyelocyte, band cell, and then your neutrophil, we'll just say. If you have a leukemoid reaction, you want to make mature cells. If you have a neoplasia, you'll have more of the less mature cells in this scenario. So in CML, where is the myelocyte with respect to the metamyelocyte?
It's way earlier.
It's earlier. So CML will have more of those earlier appearing mature-like cells. They're not completely mature, but they're going to be a little bit earlier, less mature. So that's why you would see the myelocyte bulge. All that means is you'll have more myelocytes than you will metamyelocytes on the peripheral smear. And that's super suggestive of CML.
How do you confirm CML?
Well, we have to then, I'd say, before I even do the bone marrow biopsy, I'd want one more thing to actually tell me if this is definitely not a leukemoid reaction. I'd want that lap score. So that lap score is low.
I was going to say, what is the lap score?
Yeah, so it's leukocyte alkaline phosphatase. It's an enzyme that's basically found in neutrophils, and it's released whenever it's in response to an infection or inflammation. So if a patient has leukemoid reaction, what would you expect their lap score to be?
It'd have to be high.
Yeah, but if they have CML, it's not going to have that lap score
Not
that's high.
necessarily an infection.
Exactly. So lap scores are usually low in patients who have CML. So if I see white count greater than 100,000, if I look at their peripheral smear, their differential, and it shows a left shift, meaning I have more of the myelocyte bulge, more of the earlier stages, not the later stages of the maturation, and I have basophilia and a low lap score, it's almost always CML, and you can say, I don't feel like it's leukemoid reaction.
Okay.
Because I don't get bone marrow biopsies in someone who has a sepsis.
Yeah.
You know what I mean?
True.
So you have to have a lot of things to really get yourself kind of like saying, I don't think that this is a reactive leukemoid reaction. I think this is something going on with the bone marrow, and I think it's CML. And when I have those enough of that like pretest probability, then I would go and say I'll do the bone marrow biopsy.
That makes sense. Okay.
Yeah.
And then with that one, you would find any types of abnormalities. You're looking at the bone marrow.
So for this, I'm looking for, so CML's weird. So remember I told you make lots of granulocytes. They could be myelocytes, metamyelocytes. They could be promyelocytes. They could even look like even almost a mature appearing neutrophil. But the biggest thing for this is that you still can't have myeloblasts. So there's 3 phases of CML, because I'm thinking this is CML right away, right? There's 3 phases. 1, the chronic phase. Most people live in the chronic phase, all right? So we call it CP-CML. Chronic phase, 80-85% of patients live in this and they don't really go beyond it. And what happens is they have a decent amount of myeloblasts in their bone marrow, but it's not significant to where it's actually causing like super bad problems with other cell lines. Less than 10% tells me it's a chronic phase. This one is less than 10%.
Yeah.
So this is probably a chronic phase CML. If I saw 10 to 19, so somewhere between that range, if this person hit on that, that's called an accelerated phase of CML. I'm getting more blasts. I would see more anemia. I would see more thrombocytopenia. I would see splenomegaly getting pretty bad. That's some signs of accelerated phase. Then there's the last phase, which is called blast phase or a blast crisis. So that's when the myeloblasts are greater than 20% in the bone marrow. That should sound familiar from the acute leukemia
Yeah, that's AML.
That's AML. So now a patient can completely convert from CML to AML.
Wow.
That's where you get concerned about with this disease, is that if the blast number reaches above 20%, greater than or equal to 20%, it's now a blast phase and you've converted the patient to AML. And that's when they can have all their cell lines drop. They can have pancytopenia. They could have leukostasis is another potential complication. So and tumor lysis syndrome. So that's the things that you get worried about with this. So that's what I would say. My suspicion is that given the super high white count with a left shift, myelocyte bulge, differential showing basophilia, low lap score, and then the presence of a bone marrow biopsy showing me that I have myeloblasts, and it's less than 10%, that's chronic phase CML. I don't think that this is a leukemoid reaction. That's the way I would go about that.
All right, well then how about, we've talked about the complications if it was a blast crisis. In this scenario, it's not. So if we're in that chronic phase, how would it be treated?
So treatment of this scenario actually would kind of come down a little bit to me knowing, well, first thing, CML. CML is a weird one where the genetic cause is the key for this one. So you remember back from ALL, there was the 1221 translocation, good prognosis. 922, or your friend, the Philadelphia chromosome, bad prognosis.
Sure.
So in ALL, the most common one is the 1221, less common is the 922. For CML, usually 90% or more of the actual problems is due to the 922 translocation, so the Philadelphia chromosome. So you can always remember Philadelphia chromosome is most likely the cause behind CML. So there's probably a 922 translocation. The only way that you confirm that is when you get that biopsy. You know how when you take a biopsy, you look at it, you're like, oh, okay, there's the blast. That determines what phase.
Yep.
You can do flow cytometry, but it's not super helpful, to be honest, with this one. And then you do the cytogenetics, which looks at the translocations. That cytogenetics, if it tells me 922, that's definitely suggestive of Philadelphia positive CML, which is most of it all the time. So you always assume it. So if that's the case, I want to target what the Philadelphia chromosome is doing. What happens is that 922, it creates a BCR-ABL1 fusion gene. And that fusion causes a protein that's a tyrosine kinase. It causes the receptor to become autoactivated. And it just triggers this receptor, this tyrosine kinase receptor, to send signals to your nucleus to cause proliferation and inhibit apoptosis so they can just survive forever.
Wow.
If I give a drug that can block that BCR-ABL, which is the tyrosine kinase, it can inhibit that signal to the nucleus. It can inhibit proliferation, and it can inhibit the actual, it can actually, in this case, stimulate the apoptosis. Because I want these cells to die, and I don't want them to proliferate.
Yep.
So that's where you treat these patients with what's called tyrosine kinase inhibitors. All it's going to do is block that BCR-ABL protein, or that tyrosine kinase, and prevent them from proliferating and stimulate apoptosis. Imatinib is the most common one. Dasatinib is another one. There's a bunch of them, but you just remember that tinibs is the way I remember it, the tinibs.
Cool.
That's the way I would do that. And funny enough, I would monitor their BCR-ABL levels. I would do the PCR, and I would just keep his eye on it, see if they're actually coming down. If they're coming down, it usually shows a good sign to the act, like a response to it. But that's usually almost any phase you can use this. If they get into the blast phase, so they convert to AML, the treatment changes.
Yeah.
Now I got to do tyrosine kinase inhibitor. I got to go back and I got to put this patient on more chemotherapy. So I'd probably have to go and put them on the cytarabine,
right,
and the daunorubicin therapy. I'd have to do that. And then on top of that, I'd also have to try and get them to get a bone marrow transplant. So that's one of the big things for this one, is if they convert to AML, it's going to change the complete therapy. So if it's in the chronic phase, the accelerated phase, you can probably get away with just the tyrosine kinase inhibitors and get them a transplant. But if they turn into the blast phase, you're not treating it as though it's AML.
Yeah.
So that's the way I would do that one. That's the big thing to remember for this.
Awesome. Well, that was the case 1. That was for our CML. Let's move into case 2, which is CLL, chronic lymphocytic leukemia.
Okay.
We have a 70-year-old male, presents with persistent fatigue and enlarged lymph nodes. The patient reports generalized fatigue and painless swelling of his neck and axillary lymph nodes over the past 6 months. He has experienced intermittent fevers and night sweats. There are no recent infections, unexplained bruising, or bleeding tendencies. His past medical history is pertinent to hypertension, and he's taking lisinopril for that. For his exam, we have vitals, BP is 128/75, heart rate is 80, temp is 37.5 Celsius, and his O2 sat is 99% on room air. For our lymph nodes, palpable, firm, non-tender, cervical, and axillary lymphadenopathy. Abdomen, we have mild hepatosplenomegaly, and for his skin, there is no petechiae or rash present. We do a whole bunch of testing. We get back the following: hemoglobin of 10.5, platelets 120,000, white blood cell count of 85,000, peripheral blood smear showing small mature lymphocytes, or as you talked about before, smudge cells.
Yeah.
Flow cytometry, we get back a positive CD5, CD19, CD20, CD23. For our bone marrow biopsy, we have hypercellular marrow with mature lymphocytes. And for our Rye staging, I hope I'm saying that right.
Yep. Yeah, you're good.
Named after Dr. Rye.
Yeah.
We have stage 2, lymphocytosis and hepatosplenomegaly.
Yes, sir.
A lot of stuff going on, a lot of testing.
Yeah, and funny enough, this kind of leukemia, sometimes it's like pretty much like indolent. You don't really know about it. Like they're usually asymptomatic, but this one, they got some symptoms.
Yeah, they do. Yeah. So out of all of these findings, we're suggestive of CLL, of course. But how do you really, like, what are things that are jumping out at you?
Yeah. So for example, CML, the biggest things there, like, and you have to remember, splenomegaly is probably the most common presentation for CML.
Right.
You can see splenomegaly with CLL.
It was mild.
Yeah, but in CML, oh boy, it can get bad.
Big boys.
So that's one of the real big things to think about. And they both can get anemia. They both can get thrombocytopenia because you're crowding out that marrow with the number of blasts or lymphocytes in these scenarios. But splenomegaly can get super severe in CML because, you're taking these kind of like myeloblasts and these kind of granulocytes and you're depositing into the spleen, and they actually start making cells. So it undergoes extramedullary hematopoiesis. So it's deposition and extramedullary hematopoiesis. These things get big, and CML, they can actually, their spleen can rupture. Wow. So that's the big fear. For CLL, they can get hepatosplenomegaly, but it's the lymph nodes. So that's usually the biggest thing is to think about that. So the Rye system, funny enough, is actually very helpful for thinking about the presentation and also the severity. So it starts off with stage 0, which is usually a patient who has lymphocytosis. So for example, I would see a super high white count because lymphocytes they're the second most abundant white blood cell, but they're going to be causing the white cell count to go up. So the white cell count's elevated, 85,000. But then when I look at the predominant cell that they pick up on the smear, which one was it?
Smudge.
Yeah, the smudge cells and the lymphocytes. So that right there tells me there's an isolated like lymphocytosis that's probably driving this up. If you actually look at the definition to actually have a lymphocytosis, an absolute lymphocytosis, is it has to be greater than 5,000 of those lymphocytes per microliter of blood. So whenever you get the differential, if you look at the actual number, it has to be greater than 5,000 to be considered a lymphocytosis. So that's grade 0. So sometimes the only way that these patients will present is stage 0. They'll come in, no symptoms whatsoever, get a CBC, white cell counts through the frickin' roof, and they get the differential and they say, oh my gosh, there's a greater than 5,000 lymphocytes per microliter. That's the way that they would present. And they're old people usually, greater than 70. If it gets worse, and the lymphocytes get enough that they actually start depositing in organs, that's when you get complications. So the next thing that also defines CLL is stage 1. Stage 1 is they have lymphocytosis, but then they have lymphadenopathy. That's the second most common thing. What does this patient have? Cervical axillary lymphadenopathy, palpable, firm, usually painless. That's the second one. Third is it goes to the spleen and the liver. So hepatosplenomegaly. So RAI stage, so that's 0, 1, we're on 2 now. That's going to be a patient who has lymphocytosis and hepatosplenomegaly. So does this patient have hepatosplenomegaly?
It's mild.
Yeah, they do. Okay. The next thing, and this is where it gets a little bit worse. So now we go to the next stage, which is going to be stage 3. Stage 3 is you have to have a severe enough anemia. So this patient has anemia, right? 10.5, but it has to be less than 10. So that's the definition of having actually RAI stage 3. So RAI stage 3, they don't reach that. because their hemoglobin is not less than 10. The reason they develop the anemia is because all those lymphocytes crowd out the bone marrow. And because they crowd out that bone marrow, guess what happens? You don't leave enough space and you can't make red cells. And then guess what else you can't make if you crowd out the space? Platelets. So stage 4, RI stage 4, is you have to have a lymphocytosis and then you have to have a thrombocytopenia. Do I have a thrombocytopenia? Technically, yes, because it's less than 150.
Right.
But guess what? It has to be less than 100,000.
Okay.
So they don't read that stage either. So that's why this patient has RI stage 2, because they technically have anemia and they technically have thrombocytopenia, but they didn't break the threshold to make that stage.
Okay.
So that's the way that they will present. Now, one other thing that really tells me this is, again, the smear. That anytime you see smudge cells, that's usually the dead giveaway. But here's what's kind of interesting. You would think that, oh, okay, I have these, I would need to get a bone marrow biopsy. They got a bone marrow biopsy, you don't need one. So you could actually forgo the bone marrow biopsy. And the best way to truly kind of like come to a confirmation is to actually do a peripheral flow cytometry. All I mean is I take the blood from the patient. Instead of me taking their cells from the bone marrow, I take it from the blood. And I take those cells and I run them through the flow cytometer. Do you remember the proteins for ALL?
No. At least I'm honest with you.
That's okay, because you know what? Some of them are present, but here's the way that we think about this one, right? So let's say I took your blood. You should have normal blood. Let's take your blood. I take your lymphocytes and I run them through the flow cytometer. It should come up with a couple different proteins that are present and spike up. You should have CD19 and CD20. All right, all of us should. If that's the case, that's a normal lymphocyte. But if it shows a spike on CD19, CD20, and then CD5, that's abnormal. So it could be mantle cell lymphoma or it could be CLL. How do I really tell the difference? I need to see one more spike. And there'll be one more spike in that CD23. So CD23, if you have CD19, CD20, CD5, and CD23, that's CLL. If you have CD19, 20, and 5, no 23, that's mantle cell lymphoma. And if you have CD19 and 20, that's a normal cell.
And in our patient, they of course did have the CD5, 19, 20, and the 23.
Exactly. So that's how we would really truly determine if a patient has CLL. We don't need the bone marrow biopsy unless it's an atypical presentation, or it's a patient I just don't know really what else is going on and I can't really make sense of it. But you truly don't need the bone marrow biopsy to confirm that diagnosis.
Well, that's nice to not have to put a patient through that.
Exactly. Yeah. So that's really what I would say is just think about the RI system, 0 all the way to 4, and again, it goes lymphocytosis, lymphadenopathy. You're always adding the lymphocytosis on top of it. So lymphocytosis plus lymphadenopathy plus hepatosplenomegaly plus anemia, hemoglobin less than 10, plus thrombocytopenia, platelets less than 100,000. That's the easiest way to remember the presentation. If you have that, the CBC shows lymphocytes that are mature appearing and smudge cells that are calling that predominant stage. Get the flow cytometry and you should be able to make the diagnosis.
All right. How about any complications for CLL?
So CML, biggest one was splenomegaly. CLL, believe it or not, you can actually turn into a specific type of lymphoma. So it's actually scary, really terrifying. So let's say that you have a patient, right? Start off with CLL. And here's another thing, I want to add this. There's a disease called CLL, which is chronic lymphocytic leukemia, and SLL, small lymphocytic lymphoma. They're technically the same thing. It's a different presentation of the same disease. So you have the mature appearing lymphocytes, they deposit into the lymph nodes and they cause lymphadenopathy, right? If you have lymphadenopathy and your lymphocyte count is less than 5,000, it's small lymphocytic lymphoma. That's really the big difference, is that if it's greater than 5,000 cell count in the blood and you have lymphadenopathy, it's technically CLL, but if it's less than 5,000 and you have lymphadenopathy, it's SLL. So that's the first thing. But let's say that a patient came in, all right, they have a super high white count, lymphocytosis is pretty significant, they have lymphadenopathy, you're keeping an eye on them. Month, 2 months, 3 months later, something like that. They come in, doc, my lymph nodes are gargantuous. It looks like I got goiters hanging off of me. I got multiple ones forming. I have fevers, night sweats. I got chills and weight loss that's going significant. He says, okay, I'm going to order an LDH. Orders an LDH. LDH is through the roof. This patient has transformed their type of lymphoma from probably a small lymphocytic lymphoma to what's called a diffuse large B-cell lymphoma. It's called a Richter transformation. And that's aggressive lymphoma. Usually that's a non-Hodgkin's type, and they don't do well, and they can get really, really sick. So if I see a patient who has lymphadenopathy and it gets worse really, really quickly, they get worsening B symptoms, which is the fevers, the night sweats, the chills, stuff like that. And then on top of that, they also have an LDH that's really, really high. It tells me that they have a Richter transformation. They probably have diffuse large B cell. So that's one thing to really, really watch out for the lymphadenopathy, is them getting significantly worse plus worsening B symptoms. Second thing, remember I told you anemia can occur?
Yep.
And thrombocytopenia can occur? And it's because the lymphocytes are crowding out the marrow and you don't have enough room. That's not the only reason. So there's a disease called Evans syndrome. All right. Probably learned about it in anemia, probably talked about it a little bit in thrombocytopenia. So what happens is Evans syndrome is autoimmune hemolytic anemia plus ITP. It's a duality kind of problem. So the CLL, the lymphocytes, they become abnormal. They produce autoantibodies. When you produce autoantibodies, they attack your own tissues, except these tissues tend to be the red blood cells and the platelets. Mm-hmm. So they attach to the red blood cells, they attach to the platelets, they send them to the spleen, and the spleen takes them and destroys them. When you destroy your red blood cells, you worsen the anemia. When you take the platelets and destroy them, you destroy the platelets. So that's the big difference here, is that these patients can also have autoimmune hemolytic anemia and ITP. Only way that you can truly test that, do you remember autoimmune hemolytic anemia? Remember that one?
No.
But you remember you have to do the Coombs test. That's the biggest thing, is you have to do a Coombs test, which tells you if there's hemolysis or not, the direct antibody test or the Coombs test. That would be positive. So if I have a patient who has anemia, I'm going to work them up just like I would any. They'll probably have normocytic anemia. And then if I have a normocytic anemia, I always check the retic index, look to see if that's high. If it's greater than 2%, it tells me there's a lot of breaking down of red blood cells and the bone marrow is compensating. From there, I would get the smear. The smear will probably show me spherocytes. If I see spherocytes, it could be hereditary or it could be autoimmune. Then what do? I do the direct antibody test. If the direct antibody test is positive, it's a sign of autoimmune hemolytic anemia. If I have thrombocytopenia there, I always do the same thing. Thrombocytopenia, okay, cool. Let me check the smear. Does the smear show me normal or abnormal? In this case, usually in ITP, it would be some larger platelets. And then from there, guess what I have to do for ITP? I have to rule out every single other cause of thrombocytopenia before I can come to a de novo diagnosis of ITP. I'd have to rule out that it's not from the bone marrow. I'd have to rule out that it's not DIC, TTP, HUS, going on and on and on. That's the big things to remember for that.
So this is why med students do not sleep.
Yeah, probably. It's a good always to remember that things are, if you can remind yourself of things like that are in one system from the other system, it is a good way to connect between those. But autoimmune hemolytic anemia, ITP, are definitely contributive factors to a patient's worsening anemia and worsening thrombocytopenia. And it's very, very common to a degree in CLL. Let me see, any other complicated? Hypogammaglobulinemia. That's the only other one.
Say that 5 times fast.
So hypogammaglobulinemia is kind of like where you get these really sucky B cells, right? They're mature appearing, but they're not good at their job. They're not truly functional. So they turn into less functional plasma cells. So if you get a less functional B lymphocyte, it will convert into a less functional plasma cell. If you get a less functional plasma cell, it's going to make less functional immunoglobulins. If you have less functional immunoglobulins, they're supposed to neutralize or help to phagocytose bacteria or help to activate the complement system or trigger our cells to kill these bacteria, right? But now you don't have the immunoglobulins that facilitate these processes. So now the bacteria can just go ahead and just populate like bunnies, and you can end up with infections. The most common infections are due to Streptococcus pneumonia and Haemophilus influenza. Those are your encapsulated ones because these antibodies are supposed to help to kill them. If you don't have that, now you can get things like sinusitis, bronchitis, and pneumonia. So those are the only other things that potentially put this patient at risk is hypogammaglobulinemia.
All right, well, we've talked about complications for a while now. I'm just curious to know, how is CLL treated?
So it depends on that stage. So that our the RI or the REI system. So if it's stage 0, 1, 2, and I'd say the biggest thing is if you're in any of those stages, right, but you're asymptomatic, you could just observe it.
Okay.
You don't have to really do anything. Just keep an eye on them. And if they start to become symptomatic or they become unstable, that's when you have to change your kind of like therapy up.
And our patient is in stage 2, but they are symptomatic.
Yeah, and so I would probably go the route of beginning my therapy, targeted therapies for this patient. But I'd say if they have like RAI or RI stage 3 and 4, at that point you don't wait anymore. You start treating. So I'd say it's either RAI 0 to 2, asymptomatic, they're completely stable, you can just observe them, leave them alone. But if they start to become symptomatic or unstable, or they're RAI 3-4, you treat them with the appropriate targeted immunotherapy or chemotherapy.
Such as?
All right, so
I'm curious.
Yeah. So I think the biggest one to remember is it's newer targeted therapies are becoming the way of the new world, and we're kind of getting rid of the older chemoimmunotherapies. We used to use fludarabine, cyclophosphamide, and rituximab, that combo, the FCR regimen, for patients who are a little bit more on the kind of younger side, medically fit, and if they have the RAI, 0, 1, 2, and they're symptomatic, or RAI 3, 4, regardless. But now we're starting to see that the best treatment is actually starting them on a BTK inhibitor. So it's called a Bruton tyrosine kinase inhibitor. Ibrutinib is probably the most common one. It's an enzyme that's basically found inside of these cells. So when B cell receptors, they actually have an antigen that hits them. Once it hits that B cell receptor, it triggers the Bruton tyrosine kinase to trigger an intracellular pathway to cause the cells to replicate and then not die. So when you give this drug, you're basically giving ibrutinib to target that Bruton tyrosine kinase and shut down that signal to the nucleus to prevent them from proliferating and kill them. So that's the concept that we're trying to utilize now. So if a patient has the RAI, anywhere from 0 to 2, and they're symptomatic or unstable, or RAI 3, 4, we actually like to just go straight to the ibrutinib now, regardless if they're like older, young, fit. But for the exams, we're kind of keeping it to the patient who is older and less fit, where we actually use this one.
Which our patient fits that perfectly.
Yeah, exactly. But ibrutinib is going to be the way to go. But and again, and no matter what the scenario, ibrutinib is usually the first one in medical literature, or kind of how we're going by up to date. But we do the FCR one sometimes. It's not the way that we do it anymore. It's a little bit of an older school chemoimmunotherapy.
How about if our patient gets recurrent infections over and over and over again? What do you do in that scenario?
Yeah, see if they get like more greater than or equal to 2 like events of sinusitis and pneumonia, and we know that they have a diagnosis of CLL. I could consider IVIG. I would do that if it's continuously recurrent. I would push for at least more than 2 infections, recurrent infections within a 6 to 12 month period.
And IVIG is?
It's intravenous immunoglobulin.
Okay.
So you're basically giving them functional immunoglobulins, because your B cells are kind of becoming less functional plasma cells. They're making less functional immunoglobulins. You're just going to replace them with that IVIG, the immunoglobulin G, to really help them to ward off these bacteria, to help them to neutralize, to opsonize, to help with the complement activation, and then direct cellular cytotoxicity. So that's what I would do if they just keep getting infections nonstop.
And that would probably be due to the hypogammaglobulinemia.
Exactly. Because what happens is you get the pneumonia, you get the sinusitis, and then you're just going to put them on antibiotics. That's fine. It'll kill it. But if it keeps happening, that's the difference there. So that's what you want to know is, okay, if it continues to happen, I could give them some immunoglobulins that'll last them for a while, and that'll prevent these recurrent infections.
Greater than or equal to 2?
I'd say greater than or equal to 2 infections in a 6 to 12 month period.
Makes sense. Okay.
Yeah.
All right. Well, that is it. That is the podcast episode on chronic leukemia.
Yeah, that was a good one. I don't think it was as bad as the acute, and I think that's important, because acute is
a little more straightforward.
Yeah, and I think it's like it's a severe one where it's like rapid, and it can cause a lot of different complications, as we talked about. With chronic, it's more indolent. It's gradually progressive, and sometimes you can be asymptomatic, and it's more of a laboratory diagnosis.
I was going to say, it's pretty interesting how you can actually be asymptomatic with this condition.
I know, right? Well, that's what's kind of the crazy thing, is that sometimes CLL is not. It doesn't go diagnosed for a long time until you just get that CBC that shows. Can
you imagine getting a CBC and you're like, oh, my white cell count is
85,000.
What kind of infection
am I fighting off?
Holy crap, 80,000! That'd be insane.
Yeah, that's some kind of like crazy number. If I saw that, I'd be like, well, it's over.
Yeah, me too. Yep.
But no, I think that's the big thing to take away from the chronic leukemias, is that it's not as obvious and as upfront in your face as the acute leukemia. So I hope that this podcast did make sense, and I really do hope that you guys liked it. And I think it's important to remember that this is not the only way that we present this medical information.
Yeah.
We do it on our website through notes, illustrations, quiz questions. There's a lot of different ways that I can help you with spaced repetition and just really understanding that topic. So make sure you check out our website. I think there could be a lot of things to benefit from there. But this is a good podcast, man. I enjoyed it.
It's a lot of fun.
Yeah, and so I hope that you guys did. And Ninja Nerds, I love you. I thank you guys. And as always, until next time.